Oh, Hmm. Right. Hello, is anybody home?
Just some time to get the system sorted. John,
Yeah, hi.
Hi, everyone. Do you know how,
Okay, how you doing? How you doing, Abu Milan? How are you?
Alhamdulillah.
The chef everyone.
Can you see me?
How are you?
Good,
I'm
good.
fine. Guys, can you see me?
Okay, Hussein does not want to come into the webcast. Okay, I'm trying to get you in, Hussein, but you're not coming in.
Okay.
Okay,
Fine.
I'm gonna invite you again.
Thank you very
If
much.
you want to come in, you gotta come
Yes,
in.
yes. I can hear you, but I can't see you. I switch on to my laptop too. So if there's a problem with my computer,
Okay, you're there now, right?
can you see me?
Not yet.
Guys, can you see me?
You need to turn on your camera.
Okay, that's a problem.
That's the problem. You need to turn on the camera. It's at the
Okay.
bottom left of
Because
the
on
Zoom
the bottom left,
platform.
yes, on the bottom left, I can only see
There's a
you.
picture of a camera. There's a
There's no
camera there. You got to click on it.
Okay.
Bottom left of the Zoom.
Okay, just a second. I am, rather than logging on my computer, I'm logging on my laptop, which is generally set up for Zoom.
Okay, so you're using a different computer.
Yes, because at the moment on my computer, I have.
Okay, you're coming in now. Okay, you're good. Good, you came in. Okay, now you should be able to use the camera.
Oh yeah, I can see the video.
Yeah,
and
now turn on the camera.
Yeah.
There you go. Okay, we see you.
Very good. So, very, very good. So now I'm sorted. I just need to get the camera to be.
No, it's good. Your camera's fine.
Yeah, but am I fully being seen?
Have you done Zoom before?
Okay. Good evening, everyone. How are you?
I am fine. Alhamdulillah, I'm fine. Good. Thank God, I'm fine. Just wonder, guys, do you see me or should I put a chair?
Yeah, I see you. You see you yourself, right?
Yes, yes, but I'm half, my head is shot off.
Okay, well, move your head. Move your head or move your camera.
I need to move
What
the
do you
camera.
do when you pose for a picture? Do you get out of the camera or do you
Yeah,
get in front of the lens? I
I
mean,
am
there's a lens there that's supposed to show your face.
good.
It's doing, now move it. You see what you see, right? There you go. There you go. Okay.
Okay.
Look at Abdel. He knows what he's doing.
Good. So the other thing is, I do apologize. I get my talk from the computer. When I put it on PowerPoint, how do I share it with you? Just let me.
No, you've never done a Zoom before?
I did.
Okay. The way you share it is this. Okay. You see at the bottom, there's a share button, share. You see at the bottom of the Zoom screen, there's a share button.
Fine. Just
Okay,
give.
click on that share button and go to your presentation on your computer. Click on the share button. There
I
you
did.
go. Now look for your presentation. There you go. Look for your presentation. Open it up.
Yeah. Just good. I got it. So
Okay, good. Now you need to make it full screen.
good.
Okay? Yeah,
Good.
perfect.
Fine. So
Okay, remember what you did. okay? Because I'm going to introduce you first, and then
Yes.
then you have to do what you just did.
Yes, thank you. Thank
Okay.
you very much. Just, yeah.
Well, since it's your first time, maybe I won't do that. I'll just leave you where you're at
Oh,
because it looks good now.
Lock it down. Okay.
can I check up your plan?
Abdel, I cannot make you host.
Yeah, how long is the presentation? How long is my talk?
Well, as long as you want.
Can it be
45 minutes, an hour, because it's a subject that I think is very interesting.
okay?
Even
Fine.
even if it's just recorded, even if we don't get a lot of people. Well, I think a lot of people will watch it once it's recorded.
Fine. I'm ready when you're ready.
Okay, we got about, okay, let's wait a few minutes. So wait for some more people to come in. What do you think, Abdel?
Abdel Rahman.
Yeah,
Aywa.
hold on. Abdel, I'll introduce you first, okay? And then you can introduce Hussein, okay? Do you want to do that or do you want me to introduce him? What do you want to do, Abdel? Do you want to introduce Hussein or do you want me to?
Abdul
Hello,
Rahman, can you hear?
Abdel, can you hear me? I can't hear you, Abdel.
أيوة ليه again.
Yeah, let me introduce him, okay? Because
I-
I speak better English, okay?
Okay.
Okay. But I'll introduce you to say hello,
Okay.
okay? Is that okay?
Okay.
So wait one more minute, okay, Hussein?
Okay. ل now Prof Hussein al-Maghraby will talk about artificial intelligence and stimulation and stimulation and patient specific 3D printed his trajectory guide 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 and its application in spine. Prof Hussein al-Maghraby, professor of neurosurgeon at hospital Cavity and Warwickshire, London, United Kingdom.
Thank you very, very much, everyone. I feel I'm very, very privileged to be with you and
No,
to join
hold
you.
on, we haven't started yet. Hold on. Hold on. Let's wait, okay. There's some people here. Ahmed, okay, Ahmed's here. Maybe Ahmed can introduce this. Ahmed, are you there? You need to come in, Ahmed. Okay, Ahmed, you come in.
Okay.
Excuse me. I think Ahmed's coming in. Okay, I think he is in here. Ahmed, are you there?
Yeah, I'm hearing me. Do you hear me, sir?
Yeah, can I see your picture? Your picture not on yet.
Just a minute. I would like first to you know, to make.
Yeah, see if you can get the webcam going.
Okay, just a minute. Can
There
you
you
see me
go.
right now, sir?
Okay, Abdel. Ahmed, can you introduce Hussein?
What about Abdurrahman? Abdurrahman, if he's around, he can do it as he is the
No,
organizer.
Abdel, it's hard to understand him. If I can introduce him if you want. Okay.
Get on.
Yeah, I'll do that. Okay, you ready to start, Hussein?
I'm ready. Yes, I'm ready.
Okay, here we go. Here we go. Let me start. 10, hold on. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good afternoon. This is Dr. John Bennett, televising from Miami Beach, right behind me with the beach that's really there. We have another webcast from the Yemen community. They're very active, thanks to Ahmed and others, and Abdel Alater. He's also hosting today. We're blessed with the presence of Hussein Maghraby from the University Hospital of Coventry in Warwickshire. He's going to talk about artificial intelligence and patient-specific 3D printed trajectory guide and its application in the spine. And Hussein will take as long as he wants, maybe 45 minutes, an hour, because it's a very interesting topic, and which will be useful after it's recorded today, because the neurosurgery community wants to know about this subject. So welcome, Hussein. It's all yours.
Thank you, John. Good afternoon, everyone, and hope it was a good day for everyone and still remains a nice day. My name is Hussein Maghraby. I'm from the United Kingdom, from Coventry. The work which I'm going to speak about is something I believe is new, and in reality, it can be applied in every neurosurgical and spine unit in the country. I'm giving the talk from Cairo, Egypt, where I'm there for a couple of days. And as we all know, it's Ramadan month, and now is the time for breaking the fast. So you will hear the back noise of the prayers for the sunset, which means it's the end of the day for fasting. That's what you hear in the back of the noise. The reason I'm saying that I'm giving this talk in Cairo, because the credit that most of this work has been done in Cairo, and it can be done everywhere and anywhere in the world. But most importantly, it is beautiful. It can be done in centers in the developing countries and underdeveloped, where advance in technology and spine surgery is not available, and this technique can help to get a safe neurosurgery and safe spine surgery. And to summarize, it is about using artificial intelligence and using 3D pre-operative printing to make simulation gadgets which help any surgeon while he's doing an operation in spine surgery to help him to put the rods and screws in the right place. The subject will become clear and will become more obvious when we go through it. But that is the important thing about it. Why I'm saying it is important that I give it in Egypt, because in reality, this company who does the 3D is based in the United Kingdom. But I found that the technicians who does the work and planning were based in Cairo, and I met them in Cairo, and then I used them in a number of spinal cases where they helped me to do the 3D. And while I'm giving the talk in Cairo, it comes from where most of the work has been done. So I will go, and I hope we can see with me the presentation.
Yes, we can see it.
Yeah, spinal fixation is a very important part in spinal surgery. Whether we do it for trauma cases where we have fractures, whether we do it for degenerative cases where we decompress and put the rods and screws, or we do it for deformities or trauma or we have a spinal tumor where you have to decompress the spine and remove the bone, and then the spine will be unstable, and then you have to put rods and screws. And normally, when we do these things, we will have the expertise, we do it open, and we'll have the image intensifier, which is the X-ray, to tell us, to give us the real morphology of the spine, so we can put the rods and screws. And even in the best hands, whether spine, orthopedic spine, or neurosurgery, we know even with the best image intensifier, there will be chances for things to go wrong. And this is related to the deformity or the anatomy of the bones, or patients who are very obese, or the quality of the imaging. And even in your best interest, we're fully aware that there is a chance of screws being misdisplaced and being in the wrong position, which can cause significant problem. And this is a case here. We can see spinal fixation, where we can see both screws are inside the spinal canal. And certainly, when you have something like this, there will be a risk of damaging the neural tissues, and this can be anything from a spinal cord at the level of the cervical, or the level of the thoracic spine, or damaging the nerves at any level in the cervical, thoracic, or lumbar spine. And having a neurological injury will result in permanent damage. Whatever, if you rectify the position of the screw, this damage will be permanent. Also, even if you don't have a neural damage, you can cause a dural tear, and the result of it of CSF leak and the consequences of CSF leak and wound healing can be a disaster. Other than neural damage, there is a risk of vascular damage. In the cervical spine, if you want to do a lateral mass screw or you want to do a pedicle screw, there is a risk you can damage the vertebral artery. And if you damage the vertebral artery, there'll be a risk of complications from brainstem stroke, and this can be significant consequences. Can we damage any vascular other injuries in the lumbar and in the thoracic spine? If the screws are longer or malpositioned, they can damage the aorta, because the aorta is in the front of the spine. So the risk of vascular injury is real. Right. Other consequences, if you put the screws in the wrong place, outside the pedicle or outside the body, then your stability is not strong, and this will result in failure of stability and failure of fusion. So these are real things. Screw displacement is reported in the literature, and it's anything from 8% to 20%. And all of us, whatever expert we are, we put in the consent that there is a possibility of screw in the wrong position. So what happens? There are consequences to the patients. There will be medical legal consequences from it, and the surgeon will always be disappointed with the results. So in Europe and in America, to avoid this, technology moved on. So rather than just using the uniplanar image intensifier, one image intensifier, we moved on to have two image intensifiers. So we get an AP and a lateral view before we put the screws. Obviously, if we can afford to have two image intensifiers, that is a good thing to confirm that we are in the right position. What else can we do? We can have the integrated 3D image intensifier with navigation. Either you use Medtronic navigation, brain navigation. So the patient will have a CT scan, there's a navigation system, and you get your 3D fluoroscopy, and then you tell the fluoroscopy on AP and lateral where is an anatomical landmarks, and then you can start navigating. The next step forward is what we call the CTO arm and navigation, where the patient goes to the theater and you have a CTO arm and you take the pictures, you take a spin of the spine, and then you put on the navigation system, and then you can navigate using the navigation system to know where to put the pedicle screws. The most recent thing, the most advanced thing is the navigation and robotics, where you have your navigation system and then you get a robotic arm and then you on the workstation you tell the robotic arm, I want to put the pedicle, I want to use the pedicle of lumbar L4 on the right side, and the robotic will move and will tell you where to guide the screw and drill. And I'll show you this in a video. So all this technology is to help that you put the screws in the right position. There is a learning curve with this technology. The hardware is quite expensive. If I speak in a UK pound, for after having a robotic and navigation, you speak about 500,000 sterlings for one system, and this is the price of the hardware. And every case you do, there'll be consumables you have to add on. So I will show you my journey in the last 18 years as a consultant. I used to use one image intensifier. I found it very difficult, so I moved on to use 2 image intensifier, and you can see how we're going to fix the AP and lateral X-rays. And in spite, tend to be, it's a minimal invasive, it becomes very difficult, and you need many people to help you. This is using 2 image intensifiers. And you see how you fix them and to get an AP and lateral. And this is in my theater with my team planning it. Then I moved on to use the 3D image intensifier with navigation. And basically, you do a CT scan of the patient, and then you use a 3D image intensifier, and then with the navigation system, you calibrate your instruments, and you get on and use the navigation system here, and then it tells you where to guide you with the screws inside the pedicle. The pictures are okay, but they're not brilliant. I did this between the period of 2014 to 2016, before we move on and have the O-arm with the navigation. So this is in Coventry, the navigation system, the O-arm there. So the patient will come, and then you do the scan and spin and do the 3D reconstruction of the spine. And then you put a reference arm, and then you have your navigation system, and this will guide you where you put your rods and screws. And in a case of this is a case of cervical spine. You can see, it can tell you where your trajectory, and you can put your screws and wires and your screws in the right direction using the navigation. Helps, and it's very, very good. This is the robotic. This is the advanced system where I'm showing the video. So you do your spinning, and then you get a robotic. And all what you need is to tell the robotic where you want. I'll just stop it first. So basically, the patient is lying on the table, and then you do a CT scan using the OR, and you load it on the workstation. And then on the workstation, you say, I want to fix this patient from lumbar L3 to S1. And then you tell the screen, I want to fix it at the level of right pedicle L3. So it shows you the planning, and if you're happy, you approve it. And all what you need is to press on the foot pedal, and then the robotic will move to the direction. So I'll show you how it does this. And then you press on the foot pedal.
Oh my God! I haven't seen this do work. I haven't seen this before. Wow. It's all female automatic like so when your system reaches that like that gets people
So you can see the robotic is aligning you where the pedicle is, and all what you need later. So all what you know now, your trajectory, and then you do a small opening, and that you wire, and you drill your wire through the robotic arm, and then you know you're in the right place, and then you put your screws. So I'll show you the next. This is called navigation with robotics. So you're using the robotic spine, which guides you to put your guide you for the trajectory for the spine. The next view is a real case. Now, this is a real case. So the robotic has told you where to go, and then you make an opening, and then you use the robotic. You deliver the screw, and all what you need to start to deliver the screw while robotic is holding it, and you know exactly you are in the right place. So the whole thing of doing this is to confirm and to ensure that your rods and screws or your screws in the pedicles are in the correct position. And this can be done at any level using the robotics. It's very expensive. It's very accurate. I have to say technology is available, but it may not be available everywhere in the world. So what I'm going to tell you now is an alternative. It's a cheaper thing which helps to do spine surgery in a different way, and I'll explain to you all about it. But that's where Coventry and every top center in the country will have this facility. But unfortunately, this is only available in less than 1% of the dedicated spinal centers all over the world. Okay? So what about if a patient huge like this? You know, you're going to struggle. Even with the navigation, it helps you, and truly helps you with doing the case. But if you're going to use an image intensifier in this patient, whatever image intensifier you're going to use, you will never see anything because the amount of fat and tissues will overshadow you. In this case, we did the navigation. So all the navigation is very good and it's available, it's fine. But what about other units and what else can we offer? So that comes to here, it's a patient-specific 3D printed pedicle screws trajectory guide. So basically, the patient comes to you in clinic. If he's got severe lumbar canalis stenosis or whatever the pathology, you do the MRI, and if you decide this patient needs fixation, and you have a decision, you're going to fix this patient, let's assume I fix this patient from lumbar L2 to L4. So let's say a case, we're going to do this. Then you ask the patient to have a CT scan of a thin slices, 0.5 millimeter thin sizes CT scan. And the patient will have a scan, thin slices of the area you confirmed, and then they put it on a CD, and this CD will go to the company, and the company will create a 3D image of the spine using a CT. So let me show you a case. This is a 65-year-old lady who has got degenerative canalis stenosis, and we can see there is lumbar canalis stenosis at a number of levels. This is the L5, this is the L4, and L3. She's got neurogenic claudication pains, and she's got a lot of mechanical back pain. This is the axial views showing that the spinal canal is very narrow and very now it's there, and her symptoms are classic for claudication pains. Truly, you could offer her simple lumbar decompression, but also her problem is back pain and she's very obese. So I offered her lumbar decompression with fixation. And I told her that you're going to be my first patient for using the 3D planning, and she agreed for it. And the company, we did the CT scan of the spine, and this is the reconstruction of the lumbar spine. So this is her case. This is the CT of the lumbar spine, and then the company will send me the intelligence, artificial intelligence, showing these are trajectories. This is your entry point. This is a trajectory in the pedicle, and this is your entry point, end point, and will show you each level on axial, on sagittal, and will show you all the different levels and show you the length of the screw and the trajectory. And then this is going to be sent to you on your as a PDF file. And if you're happy with the trajectories, if you say, yes, I'm happy with the trajectory, what the computer has initiated, then they say, fine, if you're happy, we'll print the 3D print. If you're not happy, you want the trajectory to be changed a little bit, then on the software, you can manipulate the trajectory, can move it a little bit outside, up and down, because you can see it in 3D views and ensure that the trajectory is fine. And once you say, I'm happy with the trajectory, then print out these guides. I'll show you this. These guides will be printed. So this is before it's printed and say, are you happy? And then you say, yes, I'm happy. They're printed out. And then this is the guides where when you do your lumbar separation, you separate the muscles, and this will be at the time of surgery, available for you at the time of surgery. So you do your muscle separation, and then you put this on the lamina, and each of this is unique. This says L4, this says L3, and this says L2. This cannot sit on L3, and this cannot sit on L2, because it's taking the architecture and the shape of the spine and the lamina. So it cannot be interchangeable. It's unique. And they print the spine to you as here, and these are the trajectories. And also I'm showing you to the people who are seeing on the camera the whole thing. This is how it looks like to the patient. They print out the spine for the patient. I'm not sure whether you see it or not. So basically, this is the 3D print of the spine. This is a 3D print, and it shows you the spine, facet joints, the nerves, and all these things. And that's what you get at the time of surgery. And when you do your muscle separation, you put this there, it sits nicely, and then you drill through this. This sits nicely here. It cannot fit here. If you put it here and you put it here, it's wobbly. It only fits in this level. Truly, they give you the number of the level, but if I assume that it's not right and I put it here, it does not fit. The only place it fits, it's at the level of L3, because it's taking the shape of the curve of the lamina and the spinous process. So this will be for this level. It cannot go here, it cannot fit here, it cannot fit here. And using this, once you show that you're in the right level, then you use the drill and drill there, and the drill will take you through the pedicle screws. So the next thing I'll show you. Next thing is the wire. Let's assume that this is the wire, and you drill the wire there with the drill, and the wire goes there, and then when you take this out, the wire will be inside the pedicle, in the trajectory, in the spine. And then the wire is there, and then you can put your screw, you get a cannulated hole, to cannulate the whole thing, and then you put your normal screw. I've got one. So this is the wire. Just to show you how it's done. So this is the spine, and this is the wire there, okay? And it's in there. This is done openly. And after you've done this, you put your cannulated hole there. This is the cannulated thing, and it goes like this on the wire, and then you cannulate through like this. You cannulate all the way. You don't need any X-ray, you don't need anything, because you know you're just doing the rail wheel on the wire. So you know in the right place, and then you take the wire away, and then you take the cannulated hole away, you take this away, and then you go to your trajectory, and all what you need is to drop your screw. So all what it needs is to drop the screw, and if I got a screw here, and if I got a screw there, the screw will be dropped through in the trajectory, which will go where you created the trajectory. So this screw will go in where it's created the trajectory. So now we're going to continue with the presentation to show you some cases, but you got the idea what it's about. That is how it is. So this is the operation. This is the muscle separation, and this is the trajectory on the spine. And the next video is showing you what we do. So you, with the image, you can use images just to make sure that you're right. But the idea, this is confirmation. But the reality is, you are on the imaging sphere, getting through the trajectory with the wire on the electric drill, and you drilling your way through, knowing that you're going to the pre-planned, to the plan, and that's why using the artificial intelligence to tell you that this is where your trajectory, and the 3D printing is a print, the gadget print which we printed before, and all what I'm doing now is using the electric drill and the wire to create my path for the screws which will go in the pedicle and inside the body. And I'm just showing you how it looks like on the X-ray. So you can see it on the X-ray going all through, but I'm not relying on the X-ray. Remember, this was my first case. So I want to build myself with the technology to ensure that it's working. But nowadays, I don't need a lot of X-ray. Once I know everything's fine, I just get on and put the screws there. And you can see, as you're doing this, and after this, you disconnect the machine, disconnect the electric drill, and you got the wire. And then after you got your wire is in place, you take the electric drill away. I'm just lengthening my wire first. So this is. And I'm taking my time for you to see it. So rather than rushing, and then now I take the wire away, and then I take the simulation thing, and I use the cannulated, I use this one which I told you to do my trajectory. And then we move on. So this is how it looks like. You can see the screws put here, another trajectory, 3D printed trajectory on another level, and you can see the wires is there. And you see it like this. And here is the step which I told you, using the cannulated owl to cannulate, and this is to do the cannulation for the screws. And I'm doing it under the screen to make sure that it is in the right position. Okay? And you can see how I showed you, how I do it here. You can see it on the screen. Good. And after this, you put your screws, and you can see how beautifully the screws has been done, all in right, all in trajectory, because it is all about preoperative planning, using the artificial intelligence on the computer to show you trajectories, and then you can make some changes. But the computer has delivered for you the trajectories anyway. You can make some changes if you need, and then after this, the company prints for you the 3D print, and then you move on to the next stage. This is another case, a 70-year-old gentleman with severe bilateral sciatica, and you can see he's got L4-5 stenosis and L5-S1 stenosis. You can see how the canal is narrowed and the spinal canal is very narrow. And in this case, I want to do fixation from L3, from L4 to S1. So I want decompress, take the lamina of L4, the lamina of L5, S1, create space, and put the rods and screws. And the case, I didn't have the case here, but anyway, I'll show it to you. So this is the planning, and you can see the S1 trajectory, plan L5, L4, and you can see the company send you all these pictures, and you may say, I want the screw to move a little bit beyond the facet joint, so you can move this way. You can do whatever you want. You adjust it, and they send it to you in 3D views, and you look through it, and you play it around, and until you're happy, your trajectory is fine, then you tell them to print it. And this is the print there. And then this is at the time of surgery. So now we did the muscle separation, wide muscle separation, and then we get to put, this is the S1, and it sits there, and you can see the wire this way, and you put it, and then you put your screws again, as we mentioned, and then you move on from one level to another, and you get you take it out, and then you drop your screws again, and this is another video showing it where you put your cannulated screws. And after this, well, if you put the cannulated owl, then you don't need a cannulated screw. It's the normal screws of the normal company you use. The whole use of the cannulated oil is to put on the wire, but the screws are normal screws. Whatever company you use, you're going to use it. You don't need to change your company. This is very important because people think we need to use fenestrated screws. No, it is the normal screws which you use. And then you get on, and this is the post-operative X-ray showing the fixation. So I showed you two lumbar cases. I want to show you a cervical case, and I want to do a lateral mass fixation. You may say lateral mass fixation is very easy, don't do it. But as again, I want to trial the system to see whether it works or not. I can do even lateral mass fixation without an X-ray, but I want to use this to see whether it works. So my intention to do 3, 4, 5 lateral mass fixation, and that is the pre-planning, and they tell me where is my trajectory, and I check the vertebral artery, and I check the far away, I check the nerve root, and if I'm happy, I say, yes, I'm happy with the trajectory, please print the 3D print. So, and they're looking to me and showing me where's the vertebral arteries and where's the spinal cord. So in this case, they map the spinal cord as red, and these are the 2 vertebral arteries, and they show you this is your trajectory, and the nerve root will be coming here. So in this trajectory, you're away from the vertebral artery and you're not hitting the nerve. And these are the directions of your trajectories. And then you tell them print, and they print the cervical spine and they print the trajectories. So if this is the case here, this is a rare case. So they print you, this is the patient, this is the 3D print of the patient, and this is his spine. Okay, this is his spine. This is the spinal cord, nerves, this is C1, C2, this is 3, 4, 5, and this is the trajectory, which I told you all about it. And then when you have your trajectory, and this trajectory, this is number 3, and this is number 4. So if I take this off and put this one here, it will not fit. Okay, it only fits here because it's taking the shape. If I take this out and put this one here, put this one in the wrong position, it will not fit. Because it only fits here because it's taking the shape of the lamina, facet joints, and the pedicle. The facet joints and the lamina and the spinous process. So once it's fitting nicely, obviously they tell you the name of it, but I'm assuming that what they're telling me is wrong, and I want to see whether it's really, whether this one can fit here or not. So if I'm assuming, so I try to put this here, it does not fit. And if it doesn't fit, you don't use it. It's wrong. Only fits here. And when it fits here and you know you're in the right place, then on your trajectory, which they created the hole, there is already holes there. So you get the drill and you use the drill and you drill through. And as you drill through, you can see it's drilling, and it is far away from the vertebral artery, and it's far away from the spinal cord, and it's above the nerve. So you can see exactly where it is because it's pre-planned. So I'll show you the case here. So this is a picture of the case, and this is the patient. This is the patient. This is opening the patient as normal, and then using using the trajectory. These are the screws being inserted, and then I do my laminectomy, and you can see the post-operative X-ray. So in the case of a lateral mass fixation, beautifully done, and helps you, and less imaging, and you're confident that everything is fine, and you are in the correct position by using this. And it does not add a lot, and you don't need to change any system. Whatever company you use, you will use it. It's the idea of the 3D printing and artificial intelligence. So this is a cervical case, right? We know that lateral mass is very good for degenerative fixation, but if you've got a case of trauma, lateral mass is not rigid enough. If you don't fix the patient from the front, then your only option is to do pedicle fixation. So this is a patient who's got ankylosing spondylitis, and he cracked his spine with a 3D, with a whole through fracture. The fracture is there, and the fracture is there. So this is called a chance fracture in a patient with ankylosing spondylitis. So ankylosing spondylitis is a stick, and there's a crack in the stick. So this is a very unstable injury. One way of doing it is to go from the front and put a plate, and then from the back and do a lateral mass. But obviously, if you can do a pedicle screws, using the pedicle screws is very, very good. The problem with the pedicle screws in the cervical spine is very narrow, and there is a vertebral artery which you can see, which you can damage it. So I use this technology, the 3D printing, and you can see the print each level for you, and you can see the 3D print. Where is your trajectory? Where is the spinal cord? Where is it in relation to the nerve? Where is it in the vertebral artery? So this is all artificial intelligence pre-planning, all done in careful thinking, and it's done on a computer, so you know what it is. And once you're happy that the planning is right, you tell them, print for me the guides. So all of this is done in your office, in your leisure, and you look carefully, and you understood where is the anatomy and everything, and you do it on leisure, and then they print it. And here it is, the 3D print, which will be on the cervical, which you put it, and this will guide you through the pedicle, and you don't need a lot of images, you don't need to be concerned. It's the same principle, it's done for a cervical pedicle screws, which is hardly, only the most experts, most advanced spine surgeon will do it, and nowadays they will do it with the robotics and navigation. While what I'm offering, this way, you're doing it without robotics, without navigation, using artificial intelligence and 3D planning. Most companies will not want you to know this because it makes it destroys all the technology, because it's a cheaper version, and any unit in the world, anywhere in the world can do it. So you get on and you put your screws and you can see them, how it looks like, all in the right position. The idea is we're trying to help doctors and surgeons where they don't have advanced technology to use this. If a center can afford advanced technology, there's nothing wrong to use advanced technology. I have it in Coventry. So I'm saying if you can afford to use it, but what about if you cannot afford it? This is an answer. So this is a case of pedicle screw. This is a case of C1 and C2-3 fixation. The same way, same print. Obviously, we've been advancing in it. And the same case is the case of hangman's fracture, and it's very unstable with breaking the pedicle of C2. There's a break in the arch, and there is translation, and there's a hangman fracture in this patient. She's neurologically intact. And this case was done using navigation. And in spite we use the navigation and robotics, in spite of all of this, you can see even with the navigation, the screw went wrong and she was neurologically affected, and we had to revise that. So this is another case where you got ostodontoidum, which is compressing on the spinal cord, and the signal changes there. And the intention is to decompress and do C1-2 fixation. That is the intention. You can see the instability on AP and lateral X-rays is quite unstable in a young lady who is neurologically intact. And this to show you the vertebral artery, and this is a 3D reconstruction of the vertebral artery. This is the dents, and then you can decide your trajectory, where the trajectory, and you do the muscle separation, and then you use the same thing, the wire, which guides you in the same place, and you check it. That is operatively how it looks like. This is this is a 3D print of the spine, and this is operatively on C1 and C2. And these are the guide wires where it guide you where you put your guide wires. And this is the post-operative X-ray, little imaging, good position, and the operation is done. This case is not done yet, it's in preparation. A lady who's got odontoid compression, and we need to do decompression transoral approach and fix her from behind. Has been planned, but it's not been done yet. And this is the planning for it, for the C1-2 fixation, and this is the 3D print for it. So what does this mean? This is the technology using the artificial intelligence and 3D print, which helps you if you don't have navigation, you don't have robotics, you don't have 2C arms, you're not very well experienced, you got a very difficult case, and you want to do fixation in a place where you're not very familiar, and even if you're familiar, you want to be accurate. It is done with pre-planning. All what you need is CD to do a CT scan, 3 thin slices, and then give it to the company, and the company will do the planning for you, and then you check it. It needs to be open, cannot be done as a percutaneous, it's an open technology. You do not need to change your company screws. Whatever company you use will help you. You don't need to, it can be done at any level in the spine, whether C1, 2, upper thoracic, upper cervical, lower thoracic, lower cervical, lumbar, lumbosacral, whatever level, you can do it. It's definitely very cheap for it. And it's easy everyone to learn and do it. The curve is very minimal. You just need to be accurate, and most importantly, you're not tied to any company, to any big company. You can use whatever company which is available in your own country. All what you need is a cannulated tap to put it on the wire. That's the only instrument which you need to have, this cannulated tap on the wire. Other than this, you don't need anything else. Has got disadvantage? Yes. It only can be done in open cases. It is not for percutaneous procedure. It requires, when you do your muscle separation, you need to do a good muscle separation. So all the soft tissue needs to be taken away, because remember, the whole thing is taking the shape of the lamina and the spinous process. So your muscles need to be well separated and well dissected to be able to put this. It needs a preoperative CT scan. So if you've got a trauma case which needs urgent fixation, it wouldn't be possible, because this, you need to do a CT scan, send it to the company, do the planning, do the print. It will take an average 48 hours. So cases of which needs urgent surgery, this will not be suitable. So as I said, it's not suitable for trauma cases where urgent decompression and fixation is not done. So this is the end of my talk. This is the name of the company. It's called Surgery Nova. This is for you. The name is behind there. These are Surgery Nova. This is the website and the email. Has got an office in Cardiff in the UK. Has got an office in Egypt. It's not my company. I just use it because I knew they got an office in Egypt, and I got in contact with them, and I use it, and I'm recommending it to be used. This is my contact details. If anyone wants to ask any question or ask me whether this case is suitable or not, feel free to contact me at any time. You got my numbers, my WhatsApp, my website, and my emails. I don't have any disclosure. I don't have any financial ties with any of them, with anything. So I don't have any financial benefit. I'm here to share this to the neurosurgeons and to the spine surgeons all over the world. But I don't have any financial interest. Right. Important things. If we're going to use artificial intelligence, a young neurosurgeon, does he need to know the normal entry points and know the normal anatomy? This is a tool to help you to be accurate, but you still need to learn your normal entry points and how to do it, because if these things fail, you may use your knowledge. So this is not a technique that I forgot about learning from my peers or my seniors. You have to grab the principles of doing it open as if you're on your own, and this is not available. This is to add on to help you to put the accurate screws to make sure everything is accurate, but it does not mean that you should not learn the normal anatomy. It does not mean that the day before you're doing a complex case, you go and revise again. Where is your trajectory? What is the landmarks? This is just an add-on. But knowing your landmarks is very, very important. So I'm telling you, this is very important. You don't rely 100% on this, because there will be cases where your 3D thing is okay, but your muscle separation is not accurate, and you find that you're not able to put this, and then you have to use your skills to do it again. So please, this is not substitute for knowing your normal anatomy, trajectories, and everything. This is not a substitute not have an X-ray. You should have an X-ray. This is an add-on. Truly, the more you use it, you become familiar with it, and you'll be able to rely on it, and will shorten your time of surgery. Rather than you do it in 3 hours, you can do your whole muscle separation and everything in 2 hours. I did a case today, and it was a multi-level lumbar fixation, and I did it using this technique in an hour and half, in 1.5 hours, 90 minutes. Before, it would take me 3 hours, but with using this a 3-level fixation, it took me 90 minutes. From skin to skin, everything. I'm not an expert surgeon. I'm just a simple neurosurgeon. But I am here in front of you, because everything is recorded, and this is in front of you, telling you about something which is available, which can make life easy and can help you. And I gave you all the information for you, and I'm happy to take questions. Thank you very, very, very much for the ability to share this with you.
Thank you very much, Hussein. Let me just say a few words before you begin, Ahmed. Like you said, this is a tool for neurosurgeons to use. And one thing I want to say is these tools are going to get cheaper. Now they're expensive, but with time, they're going to get more inexpensive. And to lead the questions, Ahmed, can you lead the questions from the panelists and lead the discussion, please?
First of all, I would like to thank Professor Hussein for this impressive lecture and for his amazing experience in spine. I'm so appreciated for your for being with us and for presenting this amazing lecture. I wish I can have lecture with Your Excellency much more again, and to have much more collaboration with each other. So to me, I have no question, but I think Abdurrahman has something to say.
Okay. Thank you very much, Prof. Hussein Maghraby. The presentation is beautiful and wonderful. We are happy to work with you.
I'm happy, Abdulrahman. I'm just waiting for the question.
Yes, do we have any questions from the panelists? Anybody in the panel want to ask any questions or make any comments? Don't be afraid. Normally, people are pretty shy in these.
Okay. For everyone, you got my email, you got my mobile, you got my WhatsApp, you got my Facebook page, you got my website. Please log to it. Please text me. I'm happy to answer questions. I'm happy to be contacted. Feel free later just to ask me, and I'll be happy to respond to you.
Okay, very good. Very good.
I think that we have something. No, I mean, the time is not appropriate right now, as most of neurosurgeons getting them their dinner as they are fasting. So the time is. I mean, it's tough to attend this lecture. But anyway, I'm gonna share this lecture as it is recorded. So I'm gonna share it on my Facebook page and to let all other neurosurgeons to get access to this lecture later, maybe.
Yeah, this will forever be on the internet. This lecture is going to last because it's a quality lecture. And I'd like to thank Ahmed and Abdel for making Yemen a very active neurosurgery education channel. We really appreciate the hard work both you guys do. to bring people like Hussein to let the Yemen neurosurgical community get smarter and prepare for the future.
Yeah, absolutely, absolutely. Once we have a professor like Prof. Hussein, that means a lot for us, and that encourage other neurosurgeons to join us. Just to invite them, we just tell them, look, Professor Hussein Maghraby just invited by us and presented an amazing lecture with us. So they will say, yes, this will be impressive for us, and that, they will join us immediately,
Okay, when's the next lecture, Ahmed and Abdel? When's the next lecture? Do you know?
Rahman.
No.
Okay, we'll talk about it later. Okay, Dr. Hussein, thank you very much.
Thank you. And
Okay.
good time.
Thank you very much, Prof. Hussein Al-Maghraby, John Bennett, Dr. Ahmed Al-Ghanmi, and everyone in the meeting.
Thank you. Thank you very much.
Okay, thank you very much.